HCC. Our session director for the session is Dr. Shivru Roy Chaudhary, who's an interventional radiologist, Kolkata. I now invite our moderator, Dr. Manash Saha, who is also an interventional radiologist from Kolkata, and his panelists. With your permission, sir, I'll introduce the panelists as well. Dr. Dipanjan Panda, medical oncologist from New Delhi, Dr. Uma Dangi, medical oncologist from Mumbai, Dr. Shrikant Mota, gastroenterologist from Kolkata, Dr. Sanjay Sen, surgical oncologist from Kolkata, Dr. Shraddha Patkar, surgical oncologist from Mumbai, Dr. Rahul Krishnatri, radiation oncologist from Mumbai, and Dr. Suheen Subramandal, gastroenterologist from Kolkata. With that, I'll pass over the mic to Dr. Manas. Over to you, sir.
Hi, thank you. Is Dr. Shubhra online? Okay. Thanks for the organizing team to invite me here in this studied panel and for discussion on HCC. HCC, you all know, is a real intergoing problem and confusions remains. With all modalities, with all tests, all our theories, the outlook remains almost same, although little bit changing in recent times. As outlook was not great over the years, so lot of modalities, lot of way of treatment developed, and more things are joining in the armamentarium, more our confusion grows. So if you go to the any session or any lecture related to the HCC, your confusion actually multifolds, because when surgeons say this is the great result, interventionists they run their own shows, and medical oncologists their own way, and then SBRT. So huge armamentarium of treatment. Most of the time we actually get confused when a particular patient comes. We have all the stagings, we have all the liver disease phenotypes and everything, all investigations. Now what to do in a particular scenario, in a particular patient is a question. So in this discussion, we would try to see the common problems and how HCC in our daily practice, what should we follow and what should be the dictum in such. Although it is never foolproof, but we'll try to somehow. And I am thankful to all the panelists who are here and who are online, especially my friend Dr. Shubhra Roy Chaudhary, who actually he is not here, so he told me to conduct this session at the very last moment. So I think Shubhra is there.
Thank you very much. Thank you, Manash. Thank you very much for taking on this challenge. Thank you.
Yeah, please, would you like to start or say something?
No, I just wanted to say that you have given the introduction. I think we better not lose time. What we will do is we'll go through some case-based scenarios, but in between the case-based scenarios, I can't see the audience, but we will ask some audience questions and then we will discuss it with the panel about the audience.
Poll is not here actually.
Okay.
So we'll directly go to panelists.
Okay, so do you want to
start
put the
with
first
this, what is the staging system basically used?
Okay.
Basically,
so
HCC is a disease, we know. When all other malignancy or any other, because it's the oncology conference, so I talk about the oncology only. So in all other system, if it's a malignancy, it is only one disease, mostly. But HCC is a two disease, liver and malignancy, which can deteriorate independently or combinedly or together, right? So it is two disease, and we have to take care of both the disease to get the best result. So we have a lot of staging system. May I ask the panelist, which most common staging system you use, like BCLC, Hong Kong liver cancer staging, CLEAP, Japan integrated staging system, TNM, or others?
Thank you, Dr. Shah. So I think everybody will agree that at least 90% of medical oncologists, if not 100%, use BCLC, not because it is the best staging system. In fact, if you ask the surgeon, they would say CLEAP or Okuda might be a better system from the surgical perspective. But BCLC is used because it is mostly the easiest to prognosticate and given treatment. So because of its ease of use, the BCLC has become very popular among most of the oncologists. And with the new updated 2022 system, I think they have been fine-tuned. So I think most of us use BCLC.
This is practicality of the staging system.
Yeah, I agree.
So just one little thing on this account is that absolutely right that worldwide BCLC is the most common staging system that is used. As long as our audience, and not just the experts, our audience are aware of the heterogeneity of the BCLC, particularly in the BCLC B group, where you can have a 6 centimeter lesion to multiple replacing 60% of the liver, which is a huge variation in the, so particularly BCLC B is a very heterogeneous group, which brings into the fore some other aids or tools that have been recently made kind of very much popular, particularly in Japan and Korea. Particularly, is Srikanth there? Is Dr. Mohta, is he
Yes,
there?
sir. I'm there.
Yeah. Srikanth, related to the integrated staging systems whereby we are trying to stage the TNM like the disease extent to the function like we would do in the Japanese integrated system or BCLC. Apart from child PU, are there any other parameters that you would use in terms of assessing a patient's liver function and thereby also prognosticating the HCC?
So apart from the child pug and the MELD score, which is the most commonly used, even the ALB score is now gaining importance with the ease of its use. But still I would say that the child score, because it is also there in the BCLC, that is still the most commonly used. But yes, the MELD should be used, especially when we are considering resection. And ALB is also an easy used tool when
Would you just go over, just for the audience, so ALB is a mathematical score, it's a logarithmic mathematical score based on bilirubin and albumin, and it's not just a simple addition or multiplication, it's a combination score. So you've already talked about the child PU and the MELD, but the audience needs to be aware of ALB, particularly ALB along with platelet ALB or PALB. These are scoring systems that are proving to be potentially more accurate in the current context than perhaps child PU and MELD. It still does not replace child PU and MELD because that's what we use. And just remember for the surgeons that, in centers that do things like indocyanine green, which is obviously an invasive test, but, just by judging a liver volume, it is not good enough to say that how much is your residual liver, what is the quality of the residual liver is important. So all we want to just highlight before we start with the cases is that I think Manash was going to show the BCLC once more. I think we should see that once more, particularly the new BCLC done in 2022. This is the older one, Manash, but the new BCLC. And would the audience like to comment? Sanjay, would you like to?
If much, I'll just, with the permission of, I'll just interject that both ALB and alpha fetoprotein, they are more important for the surgeon because they are or intervention radiologist because they are into the intermediate stage, the BCLC B. Since the medical oncologist perspective, 90% of our patient comes into BCLC class C, for which they are the basic, beyond the previous BCLC system, it is the alpha fetoprotein, which is the more important because it's a prognostic, that if it is more than 1000, most probably it will never, patient will never be able to go for transplant. So for that, bridge therapy is obviously out, and the treatment intention is basically palliative. Rest of the thing are mostly for intervention radiologists, the surgeon, and sometimes the radiation oncologist to determine whether that patient is going to be useful as a resection, whether it is ICG or ALB or even the portal hypertension and those things. So there is a distinct difference between the way the medical oncologist get the patient and the surgical oncologist and intervention radiologist.
Can I say something also? In addition to what he said, ICG is also important because if we decide to go in for surgery, it will help us in determining the extent of surgery. If the retention is too much, we will go for a simple enucleation, more than 40%. Less than 10%, any major hepatectomy can be done. So that also helps us in deciding the extent of surgery.
I think the reason, Sanjara, the reason today that we wanted to put these up is simply that the audience needs to be aware of the entire spectrum of markers and tests that are available and the staging systems that are available. Although we are in our daily practice going to be using BCLC, going to be using Child-Pugh, going to be using MELD, only these and nothing more, but the extended armamentarium that we have can offer fantastic additions. That's all I'm trying to say. Manash, thank you.
Thank you. So, Shubhro, also, now this next question comes, when we treat some patients with tests, like intermediate stages or mostly we treat with tests and some other patients, how do you measure the refractoriness of or the test failure? For medical oncologist, anybody can.
Okay.
How do you measure the test failure? Would you like to answer? You know, if for your patients, you referred to us for tests.
I think the patient who has received at least 2 or more, and then there is still progression in the alpha fetoprotein as well as the size.
So we use modified RECIST criteria for that also, and sometimes these are also criteria which Shubhro, this slide was shared by Shubhro. So this is also the area.
I mean, this is from the Hepatology Society guidelines.
Okay.
These are not mine. These are from
No,
the
you shared with
Japanese.
me. That's what I said.
Yeah. So basically, I was going to come to this in between your case, Manoj, but since you are discussing this, I think, is this the right time to discuss this, do you think, or do you want to show a case and then we'll discuss this?
I think we can, because I just going to show you some prototype cases where this everything will not come in a go.
So then we have jumped one step, which is the early BCLC. So Manash will discuss that later perhaps. So if we come to the intermediate stage, for which the standard guideline and the standard of care is TACE. Now that was based on few studies from maybe 20 years back, as you know, and things are changing a little bit because medical oncology spectrum is changing quite rapidly, and we will discuss that a bit later. But regarding TACE, it is important to understand 2 concepts. One is that the loco-regional therapists must have more than 2 goes to say that it is a TACE failure, number 1. But TACE failures needs to be identified early, because you do not want a TACE failure leading on to a significantly bad liver function. Because if the liver function goes bad, Dr. Sanjashan, you would agree that you will not be able to give the treatments that are proving to be quite worthwhile in the recent few years. So in view of that, the criteria, Manash, do you want to put that slide up? The criteria for TACE failure, how do you define TACE failure?
So,
yeah. So I can't see the screen, but yeah, basically if there is...
This is more than 50% residual enhancement on imaging 1 and 2 months target lesion for 2 or more tests, more number of the lesions on than previous imaging, increasing trend of tumor markers after tests, development of vascular invasion, and development of the extrahepatic disease. I think all
of the above is the right answer.
Yeah.
Correct.
So
don't do this now.
Yeah.
Don't do this now, Manash. This is towards the end of the discussion. Don't do this now. So these questions will be later. You want to carry on with your cases. Yeah.
So let us start with our first case. Sorry. This almost prototype cases which usually we encounter in our daily practice. 65-year-old lady who is a known follow-up case of treated HCC for more than 10 years on follow-up now. She is incidentally detected to have a segment 7 swollen liver, no other comorbidity, weight about 42 kgs, AFP around 28 international units. Rest all parameters are within normal limits, no ascites, no evidence of variceal bleed, nothing. So, would you like to see the imaging also this patient? Yes. Okay. This is the plain image. This is the arterial reconstructions. This is the image. I'll show you the arterial phase and the Is it running?
Yeah, it is.
No, it is not running here.
Okay, keep going. It is.
No. Video
So
it is running. Okay.
we can see it on the
Okay,
online.
not on my screen.
Okay.
Oh,
so
sorry.
so basically, so this is a segment 5, not a segment 7, right?
Segment
So-
7.
Okay. So there is a roughly 3.5 centimeter times 3 centimeter
Yeah, it's a typical arterial
hypervascular.
enhancing venous washout.
Yeah.
Yeah. So roughly 3.5 centimeter in maximum diameter.
Okay.
So invariably this patient first comes to medical gastroenterologist because it is on your follow-up. So what is your follow-up protocol and how you investigate all these patients to get it early? You know, our aim is to get the patient early during the diagnosis, then the results are better, right? So what is your follow-up protocol? How you tell the patients to go ahead with the investigation and for say 10 years and you have to continue. So it has to be between finances and everything will play in, and what is the most frequent investigation and how frequently you do the other investigations. Can you tell us a little bit about that?
Sir, so since this patient was a treated case of hepatitis C, the follow-up would depend on whether he had cirrhosis at baseline or not. If he had no cirrhosis at baseline and he was completely cured, he would not be on our follow-up. We follow the patient up for 6 months. Once we have seen that after treatment, after 6 months, the viral load is negative, we do not follow it up, especially with the current standard of care, which has very high rate of treatment. If this patient, however, had F4 fibrosis or cirrhosis, then he would be on our follow-up, and the tumor surveillance is indicated for those with child A and child B. Child C we do not survey because they have a very low survival invariably. Child A and B would be on follow-up, and tumor surveillance we follow by ultrasound 6 monthly, and most studies have indicated that ultrasound with the combination of AFP 6 monthly is the best treatment surveillance protocol. However, since you said if there are financial constraints, then a simple ultrasound, but a dedicated liver ultrasound would suffice.
Okay. Now, what about the role of CT or MRI?
Sir, CT we would not use for surveillance at any point. However, CT we do perform if there is a new decompensation in a relatively well-controlled liver patient. Like if a patient of cirrhosis is following up with us, but he has a new decompensation like a variceal bleed, in spite of having controlled the primary etiology. Then we perform an imaging because that generally is due to an HCC or a portal vein thrombosis or a new infection. At that time, we perform a cross-sectional imaging, but not for surveillance purposes.
Suppose this patient comes to you and there is no liver failure or but on ultrasound it is normal.
Yes.
Right? So when you ask for AFP.
So AFP would be done as part of tumor surveillance 6 monthly if he is a cirrhotic.
So if AFP increased,
yes,
then
we go for CT, definitely.
Okay.
If there is a raise in AFP, then we definitely.
Would you like to go for UGIE, upper GI endoscopy for those patients?
So endoscopy would be done depending again on the baseline variceal status, or he has previously bled or not, and that would be a separate follow-up. If he has never bled, we do it in cirrhotics every 3 years if the etiology is controlled. But yes, after we get an SOL in the liver, if on imaging and we are it is suspicious for an HCC, we would go for an endoscopy because they have a higher chance of bleed as compared to same child PU status who don't have an HCC. Then we would.
Okay.
Excellent. Thank you.
So we did because of some reason. Would you would you, medical oncologist, would you, or gastroenterologist, both you can answer, though whether you like to get an FNSC biopsy of this patient who is already treated HCG. AP is marginally high, this is not considered actually.
28 is high, Manash.
Yeah?
28.
Yeah. But would you like to have any FNSC biopsy for these patients?
Not really. If the imaging is very clear that this looks like an HCC in the background of HCV or a cirrhosis, I would not really want to do a biopsy to prove that this is what it is.
I have a different take. It is not about the biopsy from the SOL, but if radiologically I am not sure that I am dealing with a cirrhotic liver or not, I would like to biopsy from the normal liver to conclude whether there is a cirrhotic background. Secondly, in that case also I need to look for a portal hypertension. So I would like to do the ultrasound to see the hepatic pressure gradient, whether it is 10 millimeter or less, and an upper G endoscopy, as our gastroenterology colleague has said, whether there is varices or not, because it will have a treatment implication whether I can go for a surgical resection of the tumor or I have to do an intervention radiology.
Once you got the sol, you will investigate anyway. Imaging will
so
anyway tell you the portal hypertension.
So biopsy of the liver is normal liver, not the SOL. Sometimes if the patient is unresectable for other causes, a biopsy may give us some tumor tissue to do some NGS so that future treatment. So these are the indications for biopsy.
Now, let me tell everybody, because we see these patients very often, we don't like to ever enter into those liver. Cirrhotic liver is a stiff liver and you don't fiddle with it. And I have seen, believe me, with a 20 or 22 GLP needle that did FNSC, patient landed up in shock after 15 days or 7 days or 10 days. So HCC, most of them are ubiquitously vascular and you don't fiddle with them if you are sure that it is HCC. Okay.
Biopsy from the liver can be done through the IJV, so you don't have to do it through
Manash, can I just interject for 1 second?
Yes.
I think the point that Dr. Shen is trying to make is more than what our ASLD or the European Association of Study of Liver guidelines talk about diagnosis of HCC. There is some renewed interest in doing the biopsy of these lesions for two reasons. One is the morphological characteristic of the HCC, and there are 5 pathological characteristics of the HCC, has got some sort of semblance to prognostication, number 1. To responsiveness of initial treatment, number 2. But most importantly is that the interest in the molecular targeted therapies and the interest in immunotherapy and the NGS that he already mentioned. So because of the recent publications that are talking about, increased survival by adding these treatments, there is a renewed interest in biopsy. I think the question is very valid, but the answer of the question should be more than what we were giving 2-3 years ago, that do not touch an HCC, because increasingly there are more indications to biopsy in a setting of an HCC.
Thank you, Dr.
But I would still not, but I would still not biopsy the normal liver, Dr. Shen, because we should be able to diagnose cirrhosis on the basis of the gastroenterologist's fibroscan or the other imaging characteristics. It's only very rarely that we'll need the portal triads at pathology to make a diagnosis of cirrhosis. So I would not try to hit the normal liver for the reasons that Manash mentioned.
I may interject here for a minute,
Yes, please.
I know a lot of interest in NGS and everything, but in HCC, I don't think the treatment currently is based on the evidence of NGS. So in the frontline setting, I would definitely not do a biopsy. Yeah, subsequently when we are exhausting and we are looking for new things, maybe at progression, we could consider the biopsy.
And
That's
when you do a
fair
biopsy,
point.
you need to be prepared for embolization or track ablation. If you are coming out, you have to embolize, that is different. And if it is not controlled, you again have to be prepared for embolization.
I think last year in
that's a-
hepatology there was a whole paper on whether to do biopsy or not in HCC, and as Dr. Rachudri very rightly pointed out, there is renewed interest in biopsy of HCC. So during our DM we read there are some cancer which you don't have to do biopsy. Yes, for diagnosis is no, but at least the case you provided in that radiology, there was no obvious features that there are cirrhosis. So anyway, but biopsy has this whole genetic things, it has renewed our interest, because we have to accept is that once that tumor is beyond liver, we don't have really too many options. Beyond one TKI
So,
plus.
Dr. Sen, I think we are because there are so many topics to cover. But yeah, bottom line is routinely we don't do a biopsy. So the ASLD also says 2 out of the 3 criteria, right? Cirrhosis, hypervascularity with washout, raised alpha fetoprotein. If 2 of the 3 criteria are present, you don't do a biopsy. But you have to not use that line as a as a be all and end all, because there is some renewed interest. Let us stop at that and we will move. Right.
So we did a biopsy and it is turned out to be HCC as expected. Anyway, can I go up to the, I think surgical oncologist also on online, Dr.
Yes.
Shraddha
Shraddha,
Patkar.
Shraddha is online.
Yeah?
Yeah, I'm here.
Ma'am,
Yeah.
what is your opinion? What is the surgical options for these patients and how we go about it?
Yeah, just to add on one single point about the biopsy, I would just take an opinion of a surgical colleague before putting in a needle. If the tumor is eminently resectable with classical features on imaging and not a very badly cirrhotic liver, AFP not too high, child A, and eminently resectable, I don't think we have a case for biopsy, whatever our diagnostic dilemma would be. And in this patient, I would also like to see the CT scan carefully to assess the venous phase to see the relation to the right hepatic vein, because it looks like it's eminently localized as well in the segment 7. And if I can get away doing a posterior sectionectomy with the other liver being normal, all parameters considered, child A, adequate future liver remnant, surgery would be the treatment for this, because she seems to be otherwise fit and HCV treated long time back.
Thank you. Now, this is the surgical option.
Completely
now
agreed.
Whole range of IR option is there. You see,
I think Dr. Shraddha has put it very nicely. If it is a non-cirrhotic liver, if the bilirubin less than say 1, if the hepatic portal venous gradient is less than 10, if there is no varices, it's a 3 centimeter or 3.5 centimeter tumor, I think surgical resection is preferred. Of course, if the patient is cirrhotic, if there are all those things are there, then obviously we can think of TACE. But given a choice, I think my choice would be getting a
not
surgery.
yet test. We have huge range of now.
But transplant is altogether a different
Let's
issue.
not forget transplant. Yes.
Let's not forget transplant. Of course, I carried away. But in this sense, transplant is definitely another option. Provided transplant is there, then that will become biggest, because it will not only cure the tumor, it will also cure the bad liver. So transplant obviously is a treatment of choice.
So we have a whole range of ablations, right? Like RFA, microwave, cryo, IRE, and then radiation oncologist will come with the SBRT. And there's fantastic results of everything, in a given setting, all things are there. So,
but just one second, Manash.
Yep.
I think when we are absolutely the patient choice and discussions have to happen, but the textbook and the guidelines will tell you, as the panel has said, that this patient should be first considered for surgical resection. Yeah. So that is a completely fair point. The only point I would like to make, Dr. Shen, to yourself and to Shraddha, and please correct me if I'm wrong. One advantage of a liver-directed treatment, whatever that is, whether that is ablative chemoembolization, combination of chemoembolization or ablation, SBRT, whatever that is, one advantage of a liver-directed therapy is what is called the test of time approach. So by doing a liver-directed treatment by which you are getting an equivalent result to surgery, you are potentially giving some time to the tumor, let's say 6 months, to the tumor to manifest itself. Suppose if this liver develops 4 other lesions, then surgery would have been perhaps an kind of over treatment or unnecessary treatment. So the attraction of liver-directed therapy is in the setting of that it offers a test of time. Shraddha, how would you react to that statement?
So I would agree, but I would super select my patients who would warrant this kind of approach. Suppose I have a patient who is badly cirrhotic, has multicentric but
Indeed.
lobe limited disease, where I'm thinking
Indeed.
maybe this patient in some point of time is going to develop opposite side lesions and the AFP
Indeed.
is very high. And these
Yes.
patients are the ones who have a borderline FLR. These are the ones whom I would like to subject to test of time. But this patient, I think I would still be in favor of going for an upfront surgical
Fair point.
resection.
Fair point. That is fair. Okay. Thank you for that. Just wanted to bring test of time into the discussion. Thank you. Yes.
Totally. I'm
Okay.
all for it in selected patients.
Yes.
So
Thank you.
this patient actually refused surgery or ablation altogether.
Sir, I just wanted, this patient is 3.5 centimeter. I think in strict criteria, he is not a candidate for, she is not a candidate for radio frequency ablation, even for microwave ablation, I think. So I think for this test is most probably the right treatment. I'm not an intervention radiologist,
because
but
the things are changing, and microwave with radio frequency ablation, you can treat little bit larger than 3 also, but what we prefer, more than 3, especially near the vessels, up to 5 centimeter, microwave is fine. You just can burn everything and treat, right? So microwave is now our preferred modality. Okay. So TACE
But
is
again,
always
based
a
on the
palliative.
I think guidelines still does not
Yeah,
say
not
about
guidelines.
5 centimeter tumor about for microwave.
Yeah, I think 3. But what I think Manash is trying to also say is that you can use a combination of TACE and microwave.
Yes.
By that, you can treat up to 5-6 centimeters.
Yes, that is possible.
So that I'll show you also how the combination we are using.
But that
in
should
some-
be TACE first, followed by microwave, Dr. Achudri, I believe.
You can, there are both the techniques are described. When you do ablation first, then the increased hyperemia at the ablation margin causes the more vascularity of the TACE material to accumulate. But the more practiced regimen is the other way around. That you do a TACE first, particularly with lipiodol, then you can mark the lesion, it becomes white. So then to get a A0 ablation, like an R0 resection, so that you get a good margin around the tumor, it becomes easier. So my practice is TACE first followed by ablation, but in Italy they do it the other way around. So you can do both.
I do the just opposite. The reason is
Yes.
that when big lesions like 5 centimeter, 6 centimeter, you got a post-test, you got a lot of syndrome, post-embolization syndrome. And if I do the core decompression like 4-5 centimeter, and you got the just periphery to embolize. So you can do in the same sitting or 2 weeks later, because microwave will not give any symptoms. Patient will not deteriorate, almost, always. Okay, because it's a one day for us. So that's why I prefer the ablation first and followed by embolization
Yes,
if
you-
we
you can
go
have
for
both.
combination. That's my way.
Okay.
But most of the people in IR follows what Shubhro says, is first test, you got the lesion very well demarcated and then ablate. So this is the way. So patient refused. Sorry, anything you want to say?
Yeah, just to Shraddha about the resection. Shraddha, just when you talk about resection in these cases, so is your go-to technique in a well-preserved patient to do a right hepatectomy, to do a right posterior segmentectomy, or only a segmentectomy? What is your go-to technique?
So it all again depends on the nature of the future remnant which is going to be staying behind, and also the anatomic relations of the tumor. So if the tumor is just about abutting the right hepatic vein, then I would go ahead and do a formal right hepatectomy. If there is a fair enough margin between the tumor and the right hepatic vein which I can safely guard, then posterior sectionectomy is a perfectly oncological sound procedure. We've had enough data to show that you take pedicle control, you are not violating any oncological principle, and you save as much as parenchyma as possible. So in cirrhotic patients, try to save parenchyma without compromising oncological margins.
Good, thank you.
So this patient opted for TACE, which is also, she refused surgery for her reasons and ablation as well. So we went ahead with the super selective TACE of this segment lesion. Now, give an idea what is this patient had. If you see this anatomy, it's a very bad anatomy. But 65-year-old lady, It's a very bad anatomy. So in first session from the femoral approach we failed, and from the second session also we went through the radial approach, and after flow diversion of this branch we could do the embolization. So follow up after, we just actually 3 monthly followed up, and we could see that there is lesion is well treated, it's a smaller in size, very dense artifact from the ear. About 1 year follow up, if you see, we got 2 small lesions. Can you see?
Okay. So high up in segment 8.
Can you show some other section?
Is that the IVC or is that a lesion?
No, this is IVC, this is not the lesion.
Yeah, so
The
this
video is
very
not
high
running,
up.
that's why.
Okay, okay. So you had local recurrence or you had a separate?
No,
lesion?
no, it's a segment 4 and segment 3. 2 tiny
So
lesions.
this is liver recurrence,
Yes.
but not local tumor progression, right? So liver tumor progression. Okay, right. Okay, so segment 3 and 4, that's fine, Manash. Let's.
So these, I think, is it running?
No, the video is not running.
No, it will run now. Just check them. I'm sorry. So
Some
2 tiny
that happened.
lesions of less than 1 centimeter in segment 4 and segment 3. So actually,
Less than 1 centimeter.
now what is your option? What do you want to do with this patient? Whom do you want to refer?
Sir, you said less than 1 centimeter.
Yeah, this just tiny lesions we could see on arterial phase enhancing venous washout.
Can you see them on ultrasound?
Yes, please.
Are they visible on ultrasound?
Yeah, yes.
They are. Okay, all right.
Sir, I would
So
probably.
no, I'll wait for panel to say what they want.
So if it is less than 1 centimeter, probably just a follow-up imaging and AFP follow-up would suffice. And once it goes more than 1, probably we would sample it, unless there is definite characteristics of HCC on the triple phase.
This is the same lesion as we are seeing in the previous images, previous imaging. It's arterial enhancing, venous washout, everything same. It's very tiny now.
So, but less
Would
than
you
1
would you do a
centimeter.
MRI?
Yeah.
I would like to do a triple phase MR to see if there are
Yes.
other lesions with that and characterize that. If there are some other lesions which are also in developing phase, then I might consider doing again a test.
Thank you, Dr. Shen. I think that's would be my approach too. I think. What about Uma? Uma, is that you?
Yeah, I'm there.
Uma, you're medical oncology, right?
Yeah.
So your questions are coming later. All right. Okay. Okay. So so I think firstly we need to make sure that it is only 2 small lesions and not many lesions, and therefore an MRI, because multifocality would point towards a regional treatment like a TACE or a tear, whereas a very local disease in terms of a 1 centimeter ultrasound visible lesion will probably be more treated by ablation. Even Shraddha will probably agree that ablation would be probably better. If it is
This is
visible
almost the
on-
natural history of hepatitis C, which we see even after treatment with either surgery
Correct,
or
correct.
local regional treatment.
Correct, correct. Shraddha. So I think you would agree that if they are ultrasound visible, easily targetable, classic 1 centimeter HCC nodules, then probably ablation would be easier.
Yes.
If they are multifocal, regional, then a regional treatment like a repeat test like Dr. Shen said, or maybe we should keep tear even as a reserve, even not use tear right now.
Dr. Raichaudhuri, just for, I am Dr. Panda, I am the medical oncologist, sir.
Oh, I'm sorry.
That's all right, sir.
Sanjay Shen is-
Now again patient refused same any.
Just to add one thing. So what about in the baseline we did give a taste. So why not an SBRT for this patient?
That's what I'm trying to ask.
I would request Dr.
Yeah.
Rahul to
See, SBRT also coming out very good data, and we have seen some wonders, right? So To tell you frankly, I am in a setup where I have everything. Okay, SBRT, I can do tear, I can do tests, I can do call ablations, we have transplant unit, we have everything. The same with Shubhro. So we are having luxury of everything, and we do sit down and discuss for every patient. Now these two lesions side by side, 1 centimeter each, is very good for SBRT, isn't it?
See, I think in HCC the problem is of plenty. It's not the lack of choices, right? Especially the liver-directed therapy. And there will be always a conflict, especially when you have too many specialists doing too many techniques together. So, but 1 centimeter or less than 1 centimeter, I would not jump for that. I would rather give it to you for doing IR things, because that's very difficult for me to target while treating. That original lesion, definitely, if surgeon is not ready to do, then if you are okay to share it with us, I'm happy to help. Right?
So what is your size criteria? Because I have seen recently 3-4 patients being refused by radiation oncologist, too small in size, or too near the diaphragm, near the pericardium.
So near the pericardium and diaphragm are relative. I would not consider too much of a problem in that. But too small in a size is definitely, because you have to understand that on CBCT, that is onboard imaging that we do to match, does not have the luxury of contrast, washout, in and out, that you have that luxury when you do it IR procedures. So, we cannot localize that. We have to match liver with the liver, and we have to be in the same respiratory phase, different ways that people do SBRTs. So in that, to miss out that 1 centimeter lesion is very easy. And I don't want to do that. That becomes too tricky.
So
but it's not doable. I can treat 5 centimeters of the liver around it, and that's okay.
So
but why would I do it?
People should understand. See, what is the size beyond which you are comfortable?
1 to 2 centimeters is fine, but I don't think in liver you would give me 1 to 2 centimeter size lesion. I would not expect also, in general.
There is a reason for it. There is a reason for it. SBRT is a non-invasive, you see?
Yeah.
That's the reason. That's a very valid reason.
No, I agree.
Cost-wise also less.
Definitely. All those discussions are okay here, but after this doesn't translate.
Yeah, so also
I
this
don't
is
think
same with us.
I don't think the cost of SBRT is less. The cost of SBRT in a private hospital comes around 3.5 lakhs rupees.
No, but that depends from private to private
Not
also.
really, not
so
really. It's
there are
cheaper.
private hospitals which will do it for 1.5 lakh also, 1 lakh also.
For us it is cheaper because
Secondly, I believe the volume of evidence for SBRT is relatively less. The bigger trials are not there. That is why. Otherwise, I think if you look from the
so Dr. Panda, I was just going to you have taken my the things from my mouth. I think Rahul, thank you very much for saying that for a too small a lesion is a relative difficulty of SBRT. To me, the role of SBRT is an evolving technique. It will come. It will have a lot of role to play in the liver, both in the setting of HCC as well as in the setting of metastasis. But as you know, that the vast majority of the trials are, if I put it the other way, when it goes to partial nephrectomy versus renal ablation, the results of renal ablation are fantastic. But why is it not completely replaced? Is because the data is less. So similarly, there needs to be some time for the data to mature. And it happens in all specialties that some time is required. But to me, the main role of SBRT in the setting of HCC are 3. One is a lesion with a concomitant portal vein thrombus, because treating the portal vein thrombus with SBRT has got 2 great advantages. It recanalizes the portal vein, it treats the tumor. Second is a lesion that is ablatable but just beyond the size of a normal microwave of RF. Let's say 4 centimeter, 4.5 centimeter. But you would consider an ablation. SBRT is superior in my book compared to microwave because it can treat a larger size tumor.
Yeah. So just to touch on 2 points that you highlighted, sir. One is the data. So there are 4 trials which are recently closed because there's very poor accrual. Despite everybody being on board, IAA large trial has been closed recently, and the co-PI is IR people, TACE versus SBRT or TACE and TARE with SBRT or without SBRT, all those trials are being closed. So accrual is poor, and somewhere, we have to accept that acceptance of SBRT in routine is far from what we talk in the book. Now, definitely, we do get portal vein thrombosis and the larger tumors or post-TACE or tear failures that we do, and they do,
So there is renewed interest, okay?
Yeah,
Even
definitely.
with tear, let me tell you, even with tear, there is a renewed interest because tear is failed associated portal vein thrombosis. To treat that, tear also failed. So now a large series is coming out with probably from Medanta, where they are treating portal vein thrombosis with tear, SBRT, and then tear for the rest of the lesion.
Yeah.
So that
That's
is
what I'm
renewed
saying.
interest.
So
It's
that's what
coming.
I'm saying. We have too much plenty of options
No,
available actually in liver.
I think
and
what
that's
Dr.
all
Roy
good.
Chaudhary has says is that in a tumor with a main portal vein thrombosis, TACE is impossible, if not
Yeah.
really
Yes.
difficult. Tear is too expensive.
Yeah.
So SBRT stands somewhere when it can actually do target the
correct.
both recanalization of the portal vein if there is a tumor thrombus, as well as treating the tumor, which you cannot do the TACE because of fear of liver failure. You cannot do tear mostly because in most of the TACE versus tear trial, tear did not show in a large trial. It is superior. In fact, against sorafenib it has failed.
Yeah.
So, and with a 12 lakh rupees, I mean, then suddenly SBRT become very, very attractive, cost effective, and maybe an
Now,
effective
then again,
treatment.
question is that if the tumor is large and there is a large portal vein thrombosis, also SBRT cannot treat. So we have to see our limitations, our advantages. So in this patient, is there any role of medical treatment? Would you like to, because she is refusing any ablation, she is refusing surgery. So next is either go for TACE, or is there any medical treatment which you want to institute in this patient?
So
No,
this
so
patient
certainly
has
for
got a
her, if she's refusing any other treatment, then she has multiple, she's a recurrent disease, she has 2 lesions now, and if she doesn't want anything else, then we can certainly give her any of the, either the ATs or BEV, but I think it's an overkill, or a single agent lenvatinib would be enough for her.
So,
So we'll come to that. Manash, do you want to, because we are already for 45 minutes and not even finished the first case.
I think
So,
Okay. So we'll go a little fast.
I think the second case
I
will be
think
easier
let's
after we
finish
know
this
all
case
the things.
because we need to go to advanced settings for the discussion in a medical oncology
Okay,
conference.
let me skip this case and go to the third case. Okay. We'll have little
So
more
just-
variety here. Okay, this is the third case, which is a 62-year-old male who is a known follow-up case of alcoholic liver disease for more than 10 years. No other comorbidity. All parameters are within normal limits. He had a history of repeated massive variceal bleed in past, which is treated in several sessions about 5 years back. Last 5 years, no bleed. Okay. Incidentally detected right-sided large swollen liver on USG. No ascites, AFP around 1200 international, more than 1200 international units. So, what is the next investigation? Is triple phase CT, right? Okay. So that's what we did. Yaar.
Okay, so is it the tumor is on the, is it
This is the
bilobar
tumor, and this is the portal vein thrombosis we have. Okay. I'm sorry, none of this video are running.
There it is running now.
Is it?
Oh, it stopped again. Okay, so we can see.
Okay,
So,
okay, yes.
so segment 4B tumor,
No, it's
portal
5,
vein
I think.
thrombosis.
And there is a portal vein thrombosis.
Yes, and also there is tumor high up on
Yes.
4.
That is actually
multiple-
not tumor, because if you saw the reconstruction, it goes with the portal vein branch. So it is,
Okay.
I think it's a tumor thrombus, what we treated like this. Okay.
So it is so performance status is what?
He is otherwise normal. There is a
So PS0, BCLC-C,
yeah,
PS0, BCLC-C and child A. Is that right?
yes. So now we have a portal vein thrombus which is separate, then tumor little up in the segment 8. Tumor is in segment 5 with a little bit extension towards the portal, main portal towards the conference, little bit. And it is around 5 centimeter in size. No ascites, normal bilirubin, all other parameters are normal, iron are normal, platelets
It's a single,
normal.
it's a solitary lesion. There
It's
are
a
no
solitary lesion and there is a portal vein thrombosis enough. If you consider that a separate lesion, is I don't know, but
No, the portal vein thrombus, Manash, is VP1, 2, 3, 4, which means that it is subsegmental,
No,
segmental.
Dr. Saha is saying just it has not yet involved the main portal vein.
yes,
has
it is a
just gone into
subsegmental. It's a
Subsegmental.
So it is VP2. It's a VP2. VP2.
So if this situation, I would certainly involve the intervention and ask if any super selective tests can be done for this patient. And depending upon that, if not, then certainly I can also involve my radiation colleagues now to ask if SBRT is possible, considering it is a solitary lesion. And again, if everybody washes their hands off, then medical oncologists are always there to give.
And don't forget the gastroenterologist. This patient is having repeated blood vomiting, so I think he needs an EVL or
upper
something.
GI.
EVL,
If we are planning, yeah.
upper GI, EVL, something needs to be done.
No, so he is not bled for last 5 years, is what
Last
the
5
history
years, no
was.
bleeding.
But anyway, he would require a chexcopy.
no, that's what we did. We did an endoscopy. The varices are there. Even you can see on CT scan, it is varices are there. But we don't need to treat, right?
So no, so if he's going to go for systemic therapy, any option like either
Yes,
Lenva or
then
Bev, then he needs the varices to be addressed, otherwise they can land up with massive bleeds.
So what will be your preferred option now? Any surgical option, ma'am?
No, no surgery.
No, definitely no.
Definitely not.
Sir, patient is having portal hypertension. He is bleeding.
Elevated alpha fetoprotein
Doctor
is
saying we'll
highly
never touch
elevated.
this patient. I can guarantee. I can sign this letter.
Okay.
Okay.
So,
now,
so,
what?
so
What
the
should be
choices are medical oncology only, SBRT, super selective TACE plus SBRT for the portal vein thrombus, or super selective TACE only, and medical oncology. Third is SBRT only. Fourth is a combination of everything.
I think this year, 2 months back, there is a paper come at JCO where they have shown TACE plus lenvatinib is superior to TACE only.
We'll come to that. I need 10 minutes to talk to you guys about those two papers.
So,
can I ask one question, sir? In this case, is just alpha fetoprotein more than 1000? Is it enough to rule out a transplant? If we don't have extrahepatic disease, why can we not
possible
consider?
if this patient is having portal vein thrombosis, tumor thrombus, and
It's a
tumor
tumor
size.
thrombus. We are saying it's not a
No,
blank
it's
thrombus.
enhancing. It's
Okay, then
enhancing,
it's-
brightly enhancing. Okay. Arterial phase enhancing and venous washout. And we have a blunt thrombus also. But blunt thrombus we are not considering.
Okay, if we are considering surely it's a tumor, then
And
it's fine.
it is a more than 5 centimeter size.
Size, would 5 centimeter be enough to rule out transplant in today's scenario with the
They
extended
don't go for
transplant
it,
criteria?
I think,
They wouldn't.
right?
In extended transplant, they would take it, sir, I think. But tumor thrombus definitely will not.
So they will go try to control the disease and then can go for transplant. But
Yeah, there
upfront
wouldn't
they
be
will
any
not.
size criteria, but I would agree with sir that you have to make sure that the person or the patient has earned the liver, because ultimately it's not going to come up on a cadaver list, it's going to be a living donor. So that somebody has to donate that liver and the recipient has to earn that liver. So some kind of downstaging therapy to assess biology before you subject the patient to transplant would be in order.
Indeed.
So now,
Also, the alpha fetoprotein is highly elevated, more than 1000.
Yes, I think 1200 was alpha fetoprotein. I don't think patient is 65-year-old.
yep.
40, sorry.
No, 65.
I think
62 or something.
Huh. So 1200 alpha fetoprotein, I think that itself is a poor prognostic factor. At least I did, that is one, more than 1000 alpha fetoprotein is not the right candidate for, now if you do a bridge therapy, now the alpha fetoprotein comes down and you think of transplant, that's altogether a different issue.
So what we did, we sat down with our radiation oncology colleague and discussed with the patient in detail. What we did is first we did a microwave ablation for the lesion. Okay. So that is also very important. We did a microwave ablation for the lesion and followed by SBRT for the portal vein thrombus. I will show you in a minute, but before that, these are the real issues which come into the practice every time. If one treatment we have to offer for this patient, what should be that? That should be. If one treatment, patient don't have money to, in private hospital, they don't cannot afford all the combination and all the fancy things, whatever their life.
Patient can afford a tear.
Tear.
Patient can't afford treatment in private hospital in tear.
I would recommend SBRT in that case if you are just going for one,
but
followed by lenvatinib or something.
Probably this patient also difficult for you because the location. The portal vein thrombus is quite up and lesion is down. So you cannot take entire volume. I discussed with our radiation oncologist. You cannot take entire volume in a single go. So you can treat only one.
No. So we do in these patients interval SBRT kind of a thing. So we treat one of the lesions at a time and the other one 6 weeks later or 8 weeks later. So that we do very commonly for these kind of challenges. Other thing that we can do is like we do SBRT alternate day. So we can treat one lesion on one day, another day is the other lesion and they go alternate depending on the hepatic reserve that the patient has. Then ascites, I'm not much bothered for radiation treatment as such, although your BCLC and everything else will change, but technically it makes my radiotherapy much more easier because the motion of the liver becomes lesser if there is ascitic fluid. You know, if there is no ascites, then liver is much more easy to move around in the abdomen with the breathing. If there is ascites, the liver is restricted in that location. You know?
So let us see.
Makes me radiation technically more easier.
So what we did is a CT guided and of course with ultrasound, we did a ablation, microwave ablation, and then next day SBRT planning was there. So we know where our ablation is. It is almost 4.5 centimeter area completely ablated, only periphery which we thought it will be there. We knew that it will be there. In the periphery some nodules were there. So after that SBRT was done and then patient came, we called the patient after 4 weeks, did a CT scan. I'm sorry, these are not running well. Are they running?
It's running and stopping. It is to do with the bandwidth.
So I think you can see this completely ablated area, and if you go up, you cannot see those portal vein thrombus again. Those which were enhancing earlier, brightly enhancing up, you cannot see those. So portal vein thrombus is completely gone in 4 weeks time. And this lesion is ablated, minimal nodulation and little bit here. So we did test for that. Now by the way, when the patient came back to us after 4 weeks, his alpha photoprotein level was 162. And then we did for residual, we did a test. And now this patient is, I think, ready for, if you want to go for transplant or anything.
That is a fantastic
Can we consider transplant in such patients? Because the failure rate would be probably high in the terms of probably the disease coming back because the portal vein is invaded. I will ask the surgical colleagues.
Absolutely.
So would you really consider transplant in this patient even if the AFP comes down?
No.
After 6 months.
Once there's
After
the
6
of
months.
vascular invasion with tumor thrombus.
No,
in it,
immediately may not be,
chances-
but now see that alpha fetoprotein level has come down. So you wait out, you see how the disease biology behaves. If that remains okay for quite a bit of time, say not immediately, but maybe after a year, you can, if there is no lesion, new lesions come back, if the patient cirrhosis, it remains stable and patient performance status and other parameters, you may consider transplant.
Yes, yes, I agree. That time we may agree.
If you see the,
So, Manoj.
after this procedure, there is a very little remaining, and I still believe there is still residuals remaining. We'll see him in 3 months' time.
Yes.
Okay?
You can do a
That's a
second
great
taste also,
outcome.
no, if it's there.
We have to follow up
We
the
have to
patient.
follow up with another taste.
Basically, if it is
required.
a stable disease, not.
So this how we did a combination.
Yes, absolutely.
Yeah, patient afforded also.
We have to keep our choices open.
Yeah.
That is the main thing.
Manoj,
It will depend on the tumor biology. If the biology is good, then we can risk transplant. If the biology is bad, I don't think.
can you hear me, guys?
Yeah.
Okay, all right. Manoj, can you please go back to those 2 slides on the more recent data that we need to talk about? Just on
I
the,
think its time is over already.
we need to have 2 minutes. If it is okay with the organizers, I need to speak to the medical oncologist for the results of the tactics trial and the results of some of the more recent trials about.
He needs 2 minutes. Okay. So we'll
So
go
very
back.
very quickly to Dr. Pandey and to Dr. You might have read the results of the recent tactics trial, which was actually the only positive trial that has come out when combination treatment has been done, combining it with TACE.
Yes, sir.
So, would you consider now routinely that patients should be on sorafenib or lenvatinib if they have got BCLC-B, and TACE should be used in between, in windows between lenvatinib and sorafenib? That is my first question.
We have not changed
And
our practice like that, but yes, that is a thought for question, definitely.
I am not sure about the tax. What was the control arm? I think it was lenvatinib alone versus lenvatinib plus TACE, if I'm not mistaken. Or that was.
That's the launch trial. That's the launch
That is
trial.
launch. Oh, okay, sorry.
So, the tactics was sorafenib plus TACE
Yes.
versus TACE alone. And this is the first trial that showed
Where they give
So these were-
sorafenib before the TACE and then they did the TACE and then they did the
So they basically started the patient on sorafenib and they stopped sorafenib for 3 days, did the TACE, and then they kept on sorafenib. And the progression-free survival was 4 months more. On the,
I always thought that is a little odd, because if I give an anti-VEGF TKI, actually the vascularity will decrease, then the TACE will become more difficult. So I don't know how they got a better survival with giving sorafenib first followed by TACE. But I have taken, but I have not changed my
But
practice.
Dr. Pandey,
I'm
the
not
logic
sure if
is
the
on
OS
2
data
grounds.
is out.
No, the logic is on 2 grounds, just to address your question, is because if I turn your argument the other way around, one of the common criticisms of TACE was that the hypoxic insult led to the, the release of all these markers, which obviously is a good immune target. But when using sorafenib, we are not using an immune agent. So that is something that for the increased release of cytokines and the tumor cells, potentially even a cause for metastasis. So if you are reducing them, then it is arguably a reason whereby TACE has an added effect when combining with
In that way,
sorafenib.
if you think in that way, yes, it makes sense.
So that is what they have claimed, and that is one. The second thing I wanted to say was that with the results of the bevacizumab and the atezolizumab results of 18 months of was it progression-free survival or overall survival?
No, but there's so IMBRA 150 is as the first trial which has shown OS advantage over sorafenib, so none else. But in Indian context, I think my experience is less than enthusiastic. So I think it is a good drug, but not all patients can, and it can be quite toxic also, especially if you forget to see if the patient is having active hepatitis B, if your HBV DNA is more than 100, and you forget to control the anti-hepatitis B and start that over enthusiastically, if you haven't checked your varices and patient has some active varices, so
massive chance.
So so this is a very expensive way to kill the patient.
Okay, so then just very quickly, so you would start the patient today, in today's day, your go-to systemic therapy is lenvatinib or sorafenib?
90% is still lenvatinib, sir. Sorafenib we don't, sir. Sorafenib, as far as I'm concerned, I'm treating HCC for I think last 11 years. I think less than 5% of our patient, and many medical oncologists agree, can actually take 400
Tolerate.
BD. I think for Indian patient, 400 BD is not the dose. We haven't done
Indian
it.
patients is 200 BD or
Yes.
yes.
On the other hand, lenvatinib is much better tolerated, except blood hypertension, and sometimes in some patients diarrhea. Of course, fatigue is I think a class problem, but still that it is a much better tolerated drug than sorafenib. So lenvatinib for 95% patient, 5% patient can afford and eligible for atezolizumab. We try to give that.
And what about regorafenib and capo?
Regorafenib in second line we've used. Again, regorafenib is most probably the most toxic anti-cancer drug, except everolimus I have used. And I think 5% of the Indian patient actually tolerate 160 milligram. Most of the, nowadays we start, at least I start with 40 for 1 week, then 80, then 120. If the patient tolerate 120 only, then I think of 160.
So just one question I would like to ask all of you, including Shraddha, because we'll have to finish. In the light of the recent data, and I know that the recent data is probably not mature enough. In the light of recent data, if a patient with multifocal BCLC-B patient comes to you, would you consider starting the patient on lenvatinib and then do TACE? Or would you refer the patient straight to TACE? Pardon me, I'm not trying to exclude SBRT or other techniques. I'm saying, let's not call it TACE, let's call it liver-directed therapy. So would you consider starting the patient on lenvatinib, doing the liver-directed therapy in between, and then keeping the patient back on lenvatinib? Because this is a new change, because this is not BCLC-C, this is BCLC-B.
So I don't know the proportion of patients in the launch trial who are actually BCLC-B and C separately, but it does seem to have encouraging results, and they initiated TACE on demand. So it is lenvatinib plus TACE showed some, and the primary endpoint was overall survival. So very few trials again with showing a survival benefit. I would think there is a case for adding lenvatinib to transarterial therapies. I'm just not sure about the exact numbers of BCLC-B and C which were there in the trial, but they do seem to suggest that if we have to attack them upfront,
right?
yeah.
But that BCLC-A's go either to surgery or to local ablative therapy.
I think we have just exceeded time by quite a.
Okay, all right. Well, thank you very much.
Thank you for all the panelists for such a
We thank
discussion.
all our my co-panelists and Dr. Saha and Dr. Roy Chaudhary especially. It was quite an illuminating for me.
Thank you. Fantastic discussion. I think all enjoyed it.
Manash, thank you.
Thank you, Shubham.
Much obliged.
Bye.
Much obliged. Thank you.